Thank you all very much. Okay, Pemberton is my name. We'll talk about complex abscesses and Crohn's disease. I have no disclosures, unfortunately. Intra-abdominal abscesses in Crohn's disease is my topic, and the problem is this, that 10 to 30% of patients with Crohn's disease will have an intra-abdominal abscess at some time in the course of their disease. It'll either be at the presentation of their disease, spontaneous at some point during the course of the disease, as a postoperative complication. The solution, simply put, surgery, medication, or a combination of an aggressive medical approach and PCD, or percutaneous drainage. Data has told us about penetrating disease. Over 10% of patients with Crohn's disease develop an abdominal or pelvic abscess sometime over the course of their illness, and the most likely area of involvement is the ileocecal area. Our group at Mayo looked at a population-based cohort and found that 14% had penetrating disease presenting at baseline, and then the complications of that penetrating disease over the course of their illness was 33% of complications occurred at 5 years, and fully 50% of patients had complications at 20 years. It's important too to determine where in the course of the Crohn's disease the patient is. If it's early in disease, as you see here, there's a high potential for management using non-surgical approaches when the main component is inflammatory. But as stricturing becomes more of a problem and the inflammatory disease becomes less obvious, there's a much lower potential for non-operative management in the management of Crohn's disease abscesses. The most common location in the small bowel associated with an abscess is the terminal ileum. Patients most likely to develop an abscess are those with penetrating disease who do not respond to optimal medical management. As you can see from this left-sided stoma is an ileostoma with Crohn's disease present in the subcutaneous tissues and in the terminal ileum in the intraperitoneal area. This is a classic presentation. So what about percutaneous drainage? Its early reports were in the late 80s, and the short-term outcomes were pretty good. It obviated the need for surgery in up to nearly 100% of patients over the first 3 months of the abscess presence. But longer-term outcomes were worse, that in the following year, fully 50% of patients may require surgery related to the abscess coming back. So let's look at a typical progression to percutaneous drainage of a psoas abscess. Here's a retroperitoneal phlegmon, and you can see it here, progressing to an abscess cavity with gas here. And as you see on slide C, there's percutaneous drainage of that abscess. But then the patient was operated on, and this patient then had a post-op gas-forming soft tissue infection. So this patient had the full complement of problems with abscesses, abdominal abscesses, with their Crohn's disease. What about managing Crohn's disease abscesses with biologics? And in a simple phrase, there's little data on this. The group, however, at Mayo has looked at this in the management, and the study has looked at the management of Crohn's disease abscesses in the biologic era and just published this a couple of years ago. They looked at 95 patients, 55 of whom underwent medical management with or without percutaneous drainage, and 40 underwent initial surgical management. The indications to proceed with surgery immediately were as follows. They weren't amenable to percutaneous drainage. There was a high severity of illness. In other words, the patients were quite sick. There were multiple areas of abscesses, and another group had obstructive symptoms. The baseline clinical characteristics between the two groups, medical management and surgical management, were the same, which is important. Interestingly, the numbers are small, and so therefore the difference in recurrence rates between those who underwent medical management or in percutaneous drainage alone versus those who underwent surgical management was, although 11% difference, the numbers were tiny, 6 and 9, and therefore there was no significant difference. This study found that recurrence after medical or surgical treatment was the same, perhaps a type 2 error though. The risk factor for recurrence, they found, was perineal involvement. The patients had a perineal involvement at the same time as they had intra-abdominal abscess. The risk factors for recurrence was higher. The hazard ratio for recurrence was reduced, however, from 1 in patients who received no therapy with biologics to 0.1 for those on an anti-TNF therapy, and that was highly significant. The hazard ratio of recurrence overall was high for ileal disease. In the medical versus surgical management in the TNF era, the group summarized that medical and surgical management of intra-abdominal abscesses have similar rates of recurrence. Most occur early. The history of perineal disease and active ileal disease at the abscess diagnosis are risk factors for recurring problems with abscesses. The size and duration of Crohn's disease is not a risk factor. The initiation of biologic or immunomodulator therapy post-drainage likely reduces the rate of abscess recurrence. What about phlegmons now? Let's talk about definitions. An abscess is an enhancing extraluminal fluid collection greater than 1 centimeter in size, and it's confirmed by classic CT, MRI, or ultrasound imaging, and you can aspirate pus via surgery or percutaneous drainage. Whereas a phlegmon is an ill-defined inflammatory mass. The incidence of phlegmons, about 3 to 3.5% of patients who present at the time of Crohn's disease diagnosis on CT enterography will have a phlegmon. Here's what such a phlegmon looks like. The group at Beth Israel looked at treating abdominal phlegmons in the anti-TNF era as well. They published this in 2012. Among 400 patients who were treated, 3% had a phlegmon, again about the same as the Mayo data. The median disease duration, however, was 6 years. 12 of 13 also had a concomitant abscess. All were treated with an antibiotic and an anti-TNF. And the median follow-up at 3 years, there was no infection or exacerbation. 2 patients did have surgery, 1 a loss of response, and 1 an ileal stricture after infliximab. 10 of 11 were asymptomatic, no recurrence, and they concluded that the medical non-invasive therapy approach is appropriate in some patients with Crohn's disease and internal penetrating disease, and that anti-TNF therapy may reduce recurrence rates. So looking then, the group from China in a meta-analysis of abscesses and CDs of 9 studies comparing percutaneous drainage versus surgery, a lot of patients in these studies. The conclusions or the findings were that the complication rate after surgery alone was much higher than after percutaneous drainage. But the recurrent abscesses after percutaneous drainage alone were much higher than after those patients who underwent surgery. Although they concluded or found that surgery is likely inevitable in patients with intra-abdominal abscesses and Crohn's disease, pre-op percutaneous drainage decreases postoperative complications. And I really do find that to be true in my practice as well. Percutaneous drainage has converted emergency surgery, therefore, to elective surgery in this group, in this study from Amsterdam in 2014, and increase the possibility of a successful one-stage operation when it's indicated. IV antibiotics and percutaneous drainage has become the standard of initial care. It facilitates stabilizing and optimizing patients before definitive surgery is performed, and the time frames for this are between a week and a year. Who do you consider then for medical management with or without percutaneous drainage? Those who are able to control, you are able to control active inflammation with clinical stability. There's a high inflammatory burden, in other words, early in the disease. The absence of high-grade strictures or complex fistulas is important. And patients unlikely to need surgery in the near future should be considered for medical management, or those who need quieting, trying to decrease the level of inflammation around the bowel to definitive surgery. So who should you consider for initial surgical treatment? Those who have obstructive symptoms, I think, are candidates. Those with strictures and pre-stenotic dilatation, those with multiple lesions, those who are severely ill related to their infection or their sepsis, those with a long duration of disease, and those who are medically refractive, obviously. Interestingly, neither the ACG or the AGA provides specific management recommendations for these patients, beyond stating that in general, percutaneous drainage or surgical drainage, antibiotics, and delayed resection if necessary are management options in patients with intra-abdominal abscesses and Crohn's disease. So without specific guidelines, it's not easy to construct a management algorithm, but let's try here. I'll walk through this slowly. We'll look at an abscess being discovered, and it's a post-op one. We'll start with something that we might have caused. And these patients are given antibiotics and percutaneous drainage in close observation and re-imaged fairly early. And then if you're taking the treatment over time, consider non-CT sonograms every 2 to 3 weeks. But if the abscess persists, then surgery is indicated. Let's go then to the right side of the screen, and abscesses that are spontaneous, that are large, have a fistula associated with them, or they're on steroids, put them on antibiotics, do a PC drainage, and close observation, re-image again as before. If the abscess persists, surgery is indicated. And then those patients need to be started on immunosuppressives and if necessary, delayed surgical resection. What about small areas? Small, less than 3 centimeter abscesses with no associated fistulas can be started on antibiotics and aspirated. They need to be started on antibiotics and as I said, and re-imaged again. If the abscess persists, then again you go over to the right, from here over to the surgical side or the more aggressive side with drainage, re-imaging, and surgery. Thank you all for your attention.